Hi, this is Rafael Fonseca from the Mayo Clinic in Arizona, and today I'd like to share with you some highlights of exciting studies that were presented at the 2024 American Society of Hematology meeting. First, I'm going to start with the Aquila study. This is a much anticipated study that addresses the possibility that early treatment of myeloma vis-a-vis at the face of it being smoldering may be of clinical benefit for patients. This was a randomized phase 3 study that compared daratumumab monotherapy versus active monitoring, which is currently our standard approach. It's become increasingly clear that many patients with smoldering ultimately progress. And the idea is, can we intervene in a timely fashion before we see the complications of CRAB, such as a bone disease or renal damage that our patients can endure? Now, it's important they deselect patients who would have this high risk of progression. Patients need to have an enriched plasma cell population in the bone marrow greater than 10%. And at least one of the following criteria is described in the slide: an M spike greater than 3, IgA smoldering multiple myeloma, the presence of immunoparesis. They need to have more extreme values for the ratio. And the clonal plasma cells in the bone marrow, as I mentioned, had to be elevated. Now, the Aquila clinical trial was positive. And it was positive because it showed a delayed progression to active myeloma. Well, we have two studies that have shown the same with the use of lenalidomide. This is the first one using daratumumab, which is arguably a well and better tolerated regimen. Now, there's ongoing conversation right now of which patients are ideal candidates for therapy. And in fact, soon we will see this data being presented to the FDA for perhaps what could be the approval of this medication for the early treatment of myeloma. The conversation is just started, but it's quite active, and we in the community are excited about the possibility of preventing some of these complications. Another study we saw an update was Perseus. People have heard about Perseus, published last year in the New England Journal, that addresses the combination of VRD versus Dara-VRD in transplant-eligible patients. Just a brief recap: patients get 4 cycles of induction, they go on to get a transplant, and then afterwards, they get 2 more cycles of consolidation. And as is shown in the slide, if you got VRD for induction, you would get 2 cycles of consolidation with VRD. If you got Dara-VRD, then you would get 2 cycles of consolidation with Dara-VRD. After that, patients went on to maintenance. The standard maintenance was provided to the VRD arm, which is lenalidomide. And patients who had received Dara upfront received a Dara lenalidomide as maintenance. And one of the interesting provisions was that if patients had a complete response that lasted for 24 months or longer, and patients then had 2 consecutive MRD measurements at least 12 months apart, patients could go on and stop daratumumab with a provision that if the myeloma were to relapse, they could restart it down the line. The primary endpoint for this trial is progression-free survival. Now, we have seen, these are the original results, where we see that you have at 4 years a progression-free survival of 84.3 versus 67.7. And it should be noted that most of the censoring on this curves is on the right. So the data is actually quite reliable. We don't know what the median is. Some early statistical analysis support the idea that it may be in the excess of 200 months, which, of course, if that were to be demonstrated with time, becomes paradigm changing in how we think about very long duration of benefit with initial therapy for patients with multiple myeloma. Now, we've seen as well, too, recently updates regarding the risk classification of these patients. And this is probably one of my favorite slides for Perseus, because what you can see at the very top, that solid red line, is patients who are treated with Dara-RVD who have standard risk markers. Now, as a reminder, this is 80% of myeloma patients. And essentially 4.5 years, over 90% of these patients have not progressed. So again, this could indicate perhaps that this group of patients will have that very long PFS that I mentioned. Second, you see that those with standard risk and high risk are equalized if they actually get the 4 drugs for the high risk. And not surprisingly, patients who have high risk and are only treated with the 3 drugs don't do as well. Now, we saw also updates on the GMG HD7 clinical trial that, like many other clinical trials, is using MRD as primary endpoint for analysis of efficacy of this regimen. Now, this is different. This is a trial with isatuximab. So this is isatuximab RVD versus RVD. Patients get 3 of the 6-week cycles and then go on to a stem cell transplant. And later on, they go to a phase of maintenance and consolidation. And we have seen now that the MRD rates post-transplant can be reported. And the numbers, again, are not surprising, are really remarkable, where you see the rates there of 66.2 versus 47.7 in favor of the experimental arm. I think this data and the one we just saw with Perseus and what we have seen with other studies like MIDAS now tell us that the standard of care for transplant-eligible patients has to be a quad combination that includes an anti-CD38 monoclonal antibody. And this, of course, translates into improvements as well, too, in progression-free survival. So we will continue to follow this study still early on, but with great anticipation to see what happens over time for this particular patient population. And there's been much excitement, too, for those that are not transplant eligible. We've seen a release of a number of clinical trials. This is an IMROS trial. The difference between these trials and those that are aimed for patients who are transplant eligible is just the absence of transplant, but we're using 4 drugs. So the IMROS trial, which has been also published, was isatuximab VRD versus VRD for the transplant ineligible population. And here, the primary endpoint is progression-free survival, and there's a number of secondary endpoints, as you see shown here. What we saw at the ASH meeting was an update by Dr. Orlowski that shows that with progression of time, patients continue to increase the proportion of them that are MRD negative, which is what you see here in purple. That's for the isatuximab-containing arm. One of the interesting concepts that it's permeating through the various clinical trials that we're seeing is that it doesn't matter when you get to MRD, you just get to MRD, and it's not strictly defined that you need to be MRD negative after 4 cycles or after transplant, because we're seeing with this study and several others that the MRD rates continue to go up. And this is now what I set of group under this hashtag of, more of good treatment is better. And when we have treatments that are well tolerated, like the monoclonal antibodies, I think this results in patient benefit. And this just, shows, again, but the inverse, looking at MRD positivity for those patients that are in the control arm. And even if you were to progress down the line, it is better to have the combination with the 4 drugs for patients, again, who are transplant ineligible. Another study that has been reported, and we saw updates for this at the ASH meeting, was the Cepheus clinical trial, which is a very similar study as IMBROS, but in this case now it's with daratumumab, so it's VRD versus Dara VRD. And once more, you see the primary endpoint is overall MRD negativity, but still interested in PFS, durability of this MRD, PFS2, and overall survival. Now, like the previous studies I've shown you, the MRD negativity rates are higher with the quad. So this is, 60.9% as far as the primary endpoint goes. And if you start, upping the threshold to 10 to the minus 6 with 46.2, and then you ask, okay, how long does this last? Sustain is 48.7. So this is actually great results. 2 or 3 years ago, most of us would think, well, measuring MRD is probably important for transplant eligible, but the studies for the transplant ineligible show that it matters, and it matters a lot also, regardless of whether you get the transplant or not. Now, when you compare these trials to those that use transplant, I should say there's an absolute difference in MRD negativity of about 15 percent points. So there still seems to be some benefit for the addition of transplant for those that are candidates. But this studies show very deep responses, even without the transplant. And one of the remaining questions will be, what happens if you get one of these 4 drug combinations and then you're next poised to get a transplant? If you were to be MRD negative, is there benefit? And that, of course, we don't know as of now. But in general, the paradigm of transplant eligible versus not remains. Now, another critical trial was AUREGA. And AUREGA addressed the idea that, okay, so if daratumumab is working up front, how does it work if we use it for maintenance? We had some glimpses for this already with the Cassiopeia clinical trial. And what they show, again, looking at conversion of this MRD negativity, that it was superior when you use Dara-Len versus Len alone. And this suggests once more that the continuation of effective and well-tolerated therapy seems to be the way to go for newly diagnosed myeloma patients. Now, I want to show this slide, which I think is critical, which breaks down the rate of conversion from MRD positive to MRD negative for patients who were enrolled in this trial. And to do so, I'd like to take a step back. First of all, to be eligible for this trial, you need to have gone through a stem cell transplant. Patients must have had an excellent response, but still had to be MRD positive, and they could not be exposed to daratumumab before their stem cell transplant. Now, this is of high importance because we've learned that becoming MRD negative is particularly important for patients with high-risk disease. And what I'm showing you here are the subgroups of patients that achieve that conversion to MRD negativity. As you can see there on the left, the standard risk. The next set of columns is for high risk. Then we look at the subsets of the lesion 17. The next one is the translocations and chromosome 1 abnormalities. And lastly, just chromosome 1 abnormalities. And as you can see, for patients with high risk, there is no conversion to MRD negativity with lenalidomide alone. And while a lot of conversation is going on about the optimal maintenance strategy, I would say that this data clearly shows that if the patient has any marker of high-risk disease, it should be mandatory to include daratumumab as part of the regimen, given the negative or zero conversion rate that you see with lenalidomide alone. The progression-free survival for the study was also in favor of the experimental arm. So, in other words, getting the daratumumab does provide clear evidence of clinical benefit for patients. Now, again, many of the studies we have to interpret in their totality because some of them, like this one, isolate the specific question. But we have Perseus that uses daratumumab for maintenance. We have previously Cassiopeia also that had the two randomizations that could allow for daratumumab maintenance versus not. And now this one that isolates daratumumab just on those that are MRD positive but CD38 naive. So how do we put all of this information together? I think for newly diagnosed patients, I already mentioned, I think quad should be the standard. I think all data points that maintenance with an antibody like daratumumab should be considered and probably should be used in most patients. And there's no question that if there's any indication of a high-risk marker, the patient should receive such treatment. Now, I'd like to share with you also a little bit of the belantamab studies. Belantamab is the phoenix that rises from the ashes. We had belantamab, which was used shortly in clinical practice. Through the regulatory pathway, there was a failed clinical trial that compared belantamab to pomalidomide, so it had to be withdrawn from the market. But kudos to the company for having run the clinical trials that could address whether there would be benefit of belantamab in combination. And this particular trials, the DREAM7 and the DREAM8, also published in the New England Journal and updated at the ASH meeting, show that belantamab is a very powerful anti-myeloma drug. Our audience will think and recall that one of the main toxicities of belantamab is the issue of keratopathy, which can be seen in a significant fraction of patients. But fortunately, through modifications both in dosing and schedule of the drug, this seems to be much better tolerated. And I'll show you what we heard at the ASH meeting and where this is going as we look forward. So the DREAM7 clinical trial, which essentially compared belantamab, bortezomib, and dexamethasone versus daratumumab, bortezomib, and dexamethasone, showed superiority for belantamab. So if you isolate the effect of the antibodies, belantamab came ahead. So this was no doubt a very courageous studies with PFS numbers that actually looked pretty reasonable. So everyone got excited about this, and now, of course, the next question will be, where do we position these combinations, given all the other options we have that potentially could target BCMA, including bispecifics as well as CAR-T agents. Now, the other clinical trial, the DREAM8, compared belantamab, pomalidomide, and dexamethasone versus bortezomib, pomalidomide, and dexamethasone. This was the Optimism clinical trial. So in this case, a comparison is between belantamab and bortezomib. And keep this in mind because this is going to be very relevant as I show you the next set of slides. The study, again, was positive in favor of belantamab. And we saw an update from this too from Dr. Beksak from Turkey. And if you actually look at patients who are treated in the second line, so this would be a target population for this particular combination, it is clearly superior than the idea of the use again of bortezomib. And this is very relevant, of course, for what you see on the right side, which are Len refractory patients, because nowadays, with many patients receiving Len for upfront therapy, and again, many patients receiving Len as part of the combination, the presumption is that a significant fraction of them will reach the treatment of that first relapse in that Len refractory state. So this study, again, was clearly positive. Now, if belantamab is a powerful antibody, and if we're learning that it can be better tolerated with this dose and schedule adjustments, could we think of a future where belantamab could be part of our toolbox for frontline therapy? And the DREAM7 clinical trial actually was presented by Dr. Usmani as well, too, where you see that on those columns, there's a very significant fraction of patients that have either a CR or a stringent CR, which once again, just an indirect comparison with what we see with Maya, comes out quite favorably. And one would say, well, is this enough? Well, I think it is. And I think this can lead to the idea that we should be running clinical trials that compare this to our standard protocols. In particular, I'm a big fan of Maya. So that's my go-to regimen for patients who are transplant ineligible. And in fact, I would go and say that I often prefer Maya over 4 drug combinations for this patient population for one reason alone. If you think about Cefeos, or you think about Imros, or you think about the French study benefit, the addition of bortezomib carries still a significant risk of peripheral neuropathy. And Maya is such a well-tolerated regimen that many of our patients of more advanced age can have great quality of life with very effective disease control. So that then brings us to the question, could the addition of belantamab upfront create even higher efficacy and yet spare patients of the risk of peripheral neuropathy? And for that reason, we have now the DREAM10 clinical trial, which is already open and accruing patients, which compares belantamab, lenalidomide, and dexamethasone versus dara, lenalidomide, and dexamethasone. Again, I consider this interesting because it could up the ante a little bit with efficacy over dara RD, and yet not incur that risk of neuropathy that we might see with a 4-drug combination. So once more, very, very fortunate to be in a field where all of these options are being tested for our patients. Now, we couldn't do an update without mentioning at least briefly the CARTITUDE data. This is an update on CARTITUDE 4. For our audience, briefly, just CARTITUDE 4 was patients who had 1 to 3 prior lines of therapy, where cilta-cel was compared to the standard of care arm, which could be PVD, again, the Optimism, or dara PD. And this clinical trial has been, frankly, positive. As a consequence of this, in April of 2024, the FDA gave the approval for cilta-cel to be used in patients who had 1 to 3 prior lines of therapy. And of course, we have to go back to MRD negativity. And this is now shown on the columns on the left. In red, you see the cilta-cel arm. And this is consistent with what we see in our clinical practice. As you can see there, at 10 to the minus 5 and 10 to the minus 6, a very large proportion of patients can become MRD negative. And it's so rewarding to meet with people who have completed this therapy, who perhaps are 3 months out, have gone through all the process and the rigmarole of the administration and the monitoring that happens early on, and tell you the story of, this is great, I don't have to come for infusions, I don't need to get therapy, and we're just monitoring for evidence of continued control of the disease. And the graph on the right, of course, shows you the rapidity at which these patients can go on to achieve this MRD negativity. And of course, as you start looking at patients who have the sustained MRD negativity, not surprisingly, this converts itself into improvements in PFS and OS. At the Myeloma Society meeting in September, we saw the first update regarding the improved overall survival for patients treated with cilta-cel. Now, it's worth remembering there are still some issues, particularly long-term toxicities, that we're trying to sort out as to how to prevent or predict in patients being treated with cilta-cel. But even as we get there, there is very clear evidence in favor of improved overall survival for patients who are treated in similar context as you see in CARTITUDE-4. But of course, the world doesn't stop. So what's next for CAR Ts? I think probably the most talked about new product is anito-cel, which is also a BCMA targeting agent. And Dr. Freeman from the Moffitt Cancer Center presented an update at the ASH meeting. The primary endpoint for this clinical trial is overall response rate, but they're going to look at all of the other indicators of benefit, and it's a pretty standard process for the administration of this agent. And this patients had to have received 3 or more prior lines of therapy with a target dose of 115 million CAR T cells for the patients. And just briefly, the PFS rates that you see there at 6 and 12 months are quite favorable, and compared with the best products we have out there. And of course, the same is true for overall survival. But one comment I'd like to make in the anito-cel just briefly is that one of the aspects that has caught people's attention is that there is no evidence as of now of delayed neurologic toxicity. And if this is a reflection of the structure of the CAR T itself, or whether this is a reflection of better management of patients, we don't know. But with increasing number of patients being treated with anito-cel and now being accrued to other clinical trials, we know that this presents itself as a very good opportunity for myeloma patients. This is one of my favorite updates and trials we saw at ASH. Dr. Elena Samagni from the Italian group presented the following idea. If in ALL, blinatumomab is working, why don't we think about similar approaches for myeloma? Maybe we should be using teclistamab as part of maintenance-consolidation for myeloma patients. So this is a clinical trial where they enroll patients who have completed stem cell transplant. And as you can see with the boxes, they went through a number of variations on how to administer teclistamab. So we'll have to wait for more data, and the numbers are still small, but these numbers are pretty impressive. In the 3 cohorts at 12, 6 months, and 6 months out from the administration of teclistamab, 100% of patients had become MRD negative. So we're talking about 28 patients, 26 patients, 22 patients. But if this holds true, even if it's just an approximation of what we're seeing right now, this will tell us that the early introduction of T-cell redirection, the introduction of bispecifics, and why not, perhaps even CAR Ts, will be ultimately the standard of care for myeloma patients. And if I had my magic wand and I could do something right now, it would be to think about bispecifics for patients who complete induction therapy. I want to mention 2 more things quickly. Dr. Kowalski presented an update on the use of prophylactic tocilizumab. This was an institutional experience, and what they do is they look at patients who are treated with the various bispecific antibodies. What they show, the bottom line is you can significantly reduce the rate of CRS. And when you see that, it's low level. And actually, most patients do well. Now, the reason I'm excited for this is twofold. First of all, if the studies continue and the community adopts this, and this will say that perhaps many patients will be treated with TOCI, and that they will, eliminate the need for a lot of phone calls, can be treated more as an outpatient, and so forth. But the second part, which is really one I hope for, is that bispecifics will be used across the board in oncology. And if people start becoming familiarized and comfortable with the use of bispecifics, particularly as you use something like tocilizumab, I think more practices, including small hospitals and rural practices, will start treating oncologic patients across the board with bispecific antibodies. So I'm following this very closely. And last but not least, and like we mentioned for all the other compounds and cell products, there's a continued optimization of the tools that we have. And one of the stories that needs to be told is, of course, is mezigdomide. Mezigdomide is a highly effective CELMoD. So these are new generation medications in the family of lenalidomide and pomalidomide, and now being explored in combinations. And this particular update we saw was some patients who actually had relapse and refractory myeloma, and they tried mezigdomide at various doses, as you can see there in the slide. The idea was to determine the recommended dose and regimen to be subsequently tested in clinical trials. Now, these patients had a median number of prior regimens of 3. And if you think about what has been reported with studies like locomotion, responses are less common. They're not very durable. And now here they're showing responses of 75 and 85%. Once more, if this becomes confirmed, I can see how in time CELMoDs and related molecules could ultimately replace what we currently have with lenalidomide and pomalidomide. So I know there's lots to talk about, but I hope this gives you a glimpse of some of the material we saw at the ASH meeting and why we continue to have such excitement in the myeloma community. Thank you.